Okay. Okay. Dear audience, I, Dr. Mohammad Shahid Jahan, welcoming you all to today's special program. The distinguished to honor us with his presence is legendary Professor of Endodontics, Professor Ron Franzman. Welcome you, sir, and welcome to you all, the Bangla Focus TV, on this special program. Professor Ron Franzman graduated as a dentist from the University of Amsterdam in 1984. Graduated in 1998 as a dental endodontist at SCTA and recognized by the Dutch Association of Endodontology. Worked part-time for 9 years in the odontology department of SCTA, and after 15 years of general practice with an emphasis on cosmetic dentistry. He is also a member of the American Association of Endodontics. In more than 30 years since graduation, he has taught dozens of courses and lectures at home and abroad, has been a visiting lecturer at the Pacific Endodontic Research Foundation in San Diego, USA, and has published several dental magazine articles and some dental book chapter written. He is a member of the study club for dental education, where knowledge is shared with dentists from other disciplines. His main hobby is perform root canal treatments and to solve pain complaints in the patients. In his office, he only do referral cases, microsurgery, and so on. Dear audience, welcome to our guest, Professor Ron Franzman. How are you, sir?
Thank you.
It's been great pleasure that you, in spite of having sick, you are here, and we are very grateful to become a guest with you, sir.
It's my pleasure.
Thank you, sir. Now let us have the pleasure of listening to the speech of Honorable Sir Professor Ron Franzman. First of all, I would like to request sir to describe the present situation of COVID-19 as well as the preparation and precaution of the dentist in Netherlands. Could you explain, sir?
I will. Let me see if I can bring up some slides that I wrote that makes it a little bit easier. And then I don't have to talk that much. Can you see the slide?
Yes, yes.
Okay. Well, this is about the corona precautions we take in the Netherlands. This is like a slide from a few months ago when the coronavirus was just exploding. And then it was like not really very well known and not very harmful because there were much other deadlier diseases. But if we look now, let me do it. This is maybe a little bit easier. I found Bangladesh is number 17 in the world with over 100,000 COVID cases now. But if you look at the total deaths per million of the population, it's only 9. So that's very, very little. If you look all the way at the bottom, there's the Netherlands. We had almost half the cases of COVID-19. But if you look at the deaths per million of population, that is much higher. So once the COVID was known, all of Holland was in lockdown and also the dental offices. And we couldn't work for like 6 weeks until the first wave was over. What we do now, since we are working again in the office, I will just thank you. Show you what we will do in our office to protect ourselves and our patients as much as possible against the COVID. So when the patients enter the office, they are asked to rinse their hands with alcohol to disinfect it, because you know that sorry, the hands are kind of a big transmission factor. But you can also see, this is our reception area, that we have a plexiglass shield to distance the patients from the receptionist, so that she doesn't have to be afraid, and the other way around, that they will get infected. Every patient that enters the office will have his temperature checked, and we do like triage before the patient gets an appointment. We ask them if they are sick, have been sick, or have been around people who were infected with COVID-19. And in that way, we are quite sure that we will basically mainly see only healthy patients, that the risk for contamination in the office is very small. Oh, I don't know what this one is doing here. It says, if the endodontic treatment is not easily accessible to the patient in this COVID-19 situation, and if any endodontic emergency like luxation, root fractures arises, what should be the guideline over the telephone? To be honest, I don't know, because we don't give guidelines over the telephones if there's an endodontic emergency. We always have the patient come into the office. We do the triage. We ask them if they are infected or not. We measure the temperature. But even if they have been in contact with COVID-19, we still treat that patient because it is an emergency. A few months ago, there were a few clinics in the Netherlands specially equipped with materials and dentists to treat patients who were infected, but that is not necessary anymore. So now we see those patients in our office. And this is all to do again with the triage, that we ask as much as possible so that we know how much risk there is. And also, what I said, even if there's a risk for the patient to have COVID-19, still treat them, and I will show you how we will treat the patient. This is our waiting room. As you can see, all the chairs are like 6 feet apart from each other so that patients cannot infect each other. This is like a table, only 2 chairs, and there's disinfecting wipes on the table, so the patients have disinfected their hands with the alcohol when they came in. But if they want, they can like disinfect their chairs or the seats of their chairs where they are sitting in. This is the toilet, because one way that it's possible to infect other people is at the toilet. So there's a sign, it's in Dutch, but it basically says that the toilet will be disinfected after every patient. And if they are done, if they will close the lid before they flush the toilet. Because if you are infectious and you flush the toilet, still the virus can get into the area. So we also have, when they're done, have an instruction to thoroughly wash their hands, and you can see a sink and the instruction. So in that way, we'll try to keep the risk of infection as low as possible. Then, and in the operatories, we have HEPA filters. Those are the special, this is not the air conditioning, but these are special filters that will filter the viruses and molds and pollen out of the air, so that we know that we have clean air in the office. Before we start the treatment, there's also an alcohol dispenser in the operatory, and we have all patients rinse with hydrogen peroxide for 1 minute to disinfect their mouth. And here you can see on the bottle it says 3%, but we use 1%. This is the bottle, but we dilute it as 1% is strong enough. I'm telling you, sorry, what we are doing, but I assume that basically all dentists all over the world are doing the same kind of things. This is our microscope. It's also wrapped in plastic because the microscope has so many small and hidden nooks and angles and spaces that is almost impossible to clean. But here the assistants just take the wrap off and they can replace that. Here you can see them working. This is from a surgery actually, but you can see that every treatment the microscope is wrapped, and during the treatment they are also wearing hats or caps. In this case these are surgical ones, but we bought like several colorful hats for them with like flowers and animation figures and balloons on it. Then this is from a colleague of mine, Margaret. Probably many of you know her or have heard of her. What we also do is we have a face shield. You can see that on the left slide, and it's attached to the microscope. Here you can see it's taken from underneath, and on the right side it's taken from the side. The shield is actually protecting the dentist from splashes from underneath during treatment with the patient. You can see there's a different kind of microscope, but the principles are all the same. Here you can see it a little bit enlarged. And the dentist doesn't have to wear the face shield to be protected because the microscope will do that for her. And here you can see during a surgery where the assistant is wearing a face shield. In our office, the microscopes have a special attachment for the assistant, but this is good protection for the assistant in a case like this. About the masks, we just use surgical masks. That's type 2. That's the one on the lower image. It has been proven that those are safe and good enough to protect the patient. The FFP1, FFP2, FFP3, and N95 masks, the difference is, I think, 98% protection from those and 97% protection from just a surgical mask type 2R. So that's for us reason enough to just stick with those. This is instruction for how to put on an extra gown and gloves, but we don't use that anymore. We started with the extra gowns, but now we just use our normal scrubs and dental wear for treating the patients. Although they are taken out at the end of the day, but not after every patient. We also have tests in our office, and all our personnel is tested every few weeks, and these are where it says C is the control. So those are all negative tests, so that we keep a handle on how our personnel is doing. So to protect yourself like this, that's not really necessary if you are strict with all the rules. I have a small video about how they did it a few months ago, but personally I want to skip it as I think it's outdated or already. Most of the I will show like 1 or 2 minutes. Most of those measures are in the Netherlands nowadays very exaggerated. If you look at the assistant, how she's packed and wrapped, it's shown already that that is not really necessary. They let the patient first clean and then disinfect. This is what we still do. We disinfect the credit cards or the bank cards from the patients when they want the ID, if they want to pay. But our assistants are just normally dressed in office clothing, and they are more or less protected by the plexiglass shield. This is the dentist. They are also here wearing 2 pairs of gloves over each other. One colleague of mine has worked like this. It's impossible to work like that. Also takes lots of time. Here they also advise to take extraoral pictures because the chance for contamination is smaller. We don't do that. What we absolutely always do, because we're endodontists, every patient is treated under rubber dam. So we first let the patient rinse with hydrogen peroxide, and then we put the patient under rubber dam. And that's also because of the aerosols in the air. Here they leave the room unused for 15 to 30 minutes because we have the HEPA filters. That's not necessary also. By the time the assistant is done cleaning the room, after, let's say, 10 minutes, we're basically ready for the next patient. So let's see what else we have. This is about the corona. What I have. It's about the instruments that we use and what you will call tips and tricks and advice for young dentists. In our office, I'm like a dentist for over 35 years already, and over the years I have collected and accumulated lots of nice instruments and extra equipment. If you just start, you can't expect to start like this. That's very difficult, and I think especially in your country, in your region. But we have a card with everything on it: handpieces, ultrasonic obtura system, light cure, whatever there is, we have it, and we will use it. We use digital radiography. That's especially in endodontics, where you have to take a lot of pictures, really nice to have because you have instant result. We have, I showed you that already, the size microscope with the let me take some water. With the extra tube for the assistant, and we have a camera to take pictures on the other side. We have a CT machine, a 3D machine in the office, which is like great, like the card, the microscope, the digital X-ray, and the CT are like my foremost favorite things. But as I said, it makes our life a lot easier, but it's not really necessary to do a good endo. Even just with a normal radiograph and normal files, you still can do a good endo. What I want to show here is that is something that most people aren't aware of. Those are sorry, the Senseus files. The Senseus files, they have silicone coating, and if you have to work all day, day in, day out, with a lot of hand files, which we still have to do because we see a lot of retreatment cases, and it's not possible to do all of them just with a mechanical hand piece. Then the silicone coating makes it much easier on your fingers. I can remember in my earlier days when I just graduated like 35 years ago, we had hand files in sodium hypochlorite, and at the end of the day, I actually had wrinkles in my fingers from working the files. But nowadays at the dental school, they don't teach hand filing anymore. That's becoming a lost art because everyone is doing things mechanically with handpiece, break a lot of instruments, and when it's getting difficult or complicated, they don't know how to do that anymore. If you look here at the picture of the hand files, on the bottom you see a number 08, and on the top you see a number 06. A lot of people don't know that there is something like the size 06. Not many people have them. And if you have a small or calcified canal, the 06 is about 25% smaller in size than a number 08. So that really can make a difference if you're struggling to get to lengthen a canal. So if you don't have them, they're hand files, they're not too expensive. Try to buy or try the Senseus files if you want, even that is not necessary, and have those files. If you, let's see, look at another file that we use a lot that many people don't know about, that's called the D-finders. That's because those files have the shape of a D. You can see that in the lower right picture. They just cut on one side. They break more easily than the normal nickel titanium or flexo files, but they have a very sharp point. You can't force them in the canal, then they break. But if you do like touch and go, pick in the canal when it's calcified, when there's a false root, is something that we use very often. Another thing, if you do a lot of retreatments, that is nice to use, that's the micro openers. What you see here is the blue and yellow are the debriders. Those are headstrong files, and the purple and the white ones, they're micro openers. They're very thin. And what I like about them is if you work with magnification or loop, if you work with your hands, you have a file in your hand, then you immediately block the whole entrance of your canal. With a micro opener, you can work deep in the canal, you can bend them, you can look for a lateral canal or a fausse route, and still be able to see where you are and what you are doing. Those are not expensive instruments, but in our office, we use them quite often, and they do make a difference. Then, Dr. Jan also asked me if I have some advice for young, let me go one back here, advice for some young starting dentists. It's difficult to do because I do not know the situation in your country, but what I do know is that the best dentists and the dentists that I admire very much, they are endodontists, I should say, know more than endo alone. They are all very good restorative dentists. They all have a lot of knowledge about implants. So what I should advise the starting dentists is don't concentrate only on endodontics, but also keep informed what else is happening in dentistry, because you do see emergencies, you do see patients with pain that is not from endodontic origin, that's neurogenic, or maybe just a simple sensitive tooth with hot and cold, where there's no nerve involved. So try to keep an open perspective from all that's going on, and talk with other dentists that have a lot of experience. In my time, I went and visited a lot of famous endodontists, and many of them have become good friends over the years. But there's any well-known endodontist, there's a big chance that I've been to his office, visited him, and see how they were working and what they were doing. Another thing besides that is visit the endodontist, keep track of the literature, and also very important is there are no easy cases. I only have like 2 or 3 cases a year that I think, wow, this is really great. This is the perfect case. Every other tooth that I treat is always something that I think should have done it differently, could have done it better. Always be critical of your own work, and being in a study club and discussing your cases with other dentists helps a lot. Some people join an endo study club, which I have, and some people with other dentists. I also am in a study club with 2 implantologists and a restorative dentist, a periodontist, and another endodontist. You can learn a lot from those people. I think that's for the moment the best advice I can give to people who are just starting. It's also for me, every case they do is a new experience, a new possibility to learn something. I do this for over 35 years, and I will never ever get bored with endodontics, because every case is a challenge, and every case is new, and every case I will learn something. And if you have that mentality, you can only grow and get better. And if you do that, you will distinguish yourself from the competition. In our country, there are many endodontists also. We get a lot of referrals because people know that we take care of their patients and that we do basically just a little bit better than the others do. Then the last part, hang on, let me. Dr. Showed me or sent me some questions that people had. This is one of the sorry, this is one of the questions. Are maximum types of periapical lesions curable without endodontic surgical procedures? Well, there have been, as far as I know, there have been some cases in the literature when they did not, and they got better. We don't know why, but the main rule is still for 99.999% that if there's an apical lesion, that you need an endodontic surgical or an endodontic procedure. Let me see if I got the question right. Maximum types of periapical lesions. So, maybe I didn't understand the question right, but periapical lesions curable without endodontic surgical procedures. Yeah, if you do a good endo, a normal root canal treatment disappear. I don't know. I hope that I will give the right answer. When a patient is in my office, I always tell them when they come for a difficult treatment that we have 90% chance of success. If the treatment fails, we still can do surgery, and of the surgery, 9 of the 10 will have success. So out of the 100 teeth that we treat and retreat, 90% will heal by itself. 9% will have probably some other kind of treatment, meaning surgical procedures, and 1 out of 100, either there is nothing we can do, whatever we do, it will not help, or there was maybe another reason for the lesion that we didn't notice. And then another question was, nowadays there's a variation of root canal and anatomy that are more common. If any accessory canal is missed, how much can it affect the outcome? Well, how much, that is difficult to say. We can only say that it can affect the outcome. We all have seen those root canal treatments that there were canals missed, hardly filled, hardly treated, and still the lesion was healed. According to Tronstedt, that might be because the coronal lesion was very good and there was a little disinfection enough, and the tooth was sealed very well. And probably everyone must have the same that I had, that you did a root canal treatment that you thought, well, this looks fantastic. This is one of the best treatments of the year. 6 months later, the patient comes back and the lesion is either not gone or there wasn't a lesion and it has developed. So it can go either way. But the main thing to remember is it's bacteria that cause the lesion or the problems. And the better and the more canals you clean, and you clean well, then the less chance there is that your treatment will fail. And then, is steroid-mediated pulp devitalizer safe? Well, let me put it another way. It's not really unsafe, but why would you put a steroid in a pulp canal, because if you need to devitalize the pulp, it's better to just take the whole pulp out and mix it with sodium hypochlorite. And if you have to do multiple sessions, put something like calcium hydroxide in the canal. In Holland, we had pulp devitalizers, but they were based like on formocresol, non-steroids. Steroids don't devitalize pulp. They take the inflammation away, so they will just make the inflammation less. What you use in the canal on steroids is so little that it can't harm the body. So if you're using it and still want to use it, I don't see any reason why it could be unsafe. But if you want to help the patient, then it's probably better to just extirpate, rinse the canal with sodium hypochlorite, and then either complete the treatment or put calcium hydroxide in. But again, there's nothing really wrong with steroids. If it's just a steroid, if you have like those ointments with, I don't know the name, because we don't use it in the Netherlands, but there were like some medicaments that had like everything, steroids, but also it's well known in Bangladesh, but not in Holland. Besides the steroids, probably also formocresol and calcium hydroxide, and I don't know. It was a whole mix with very bad stuff that you don't want in your root canal. So if you're referring to that, no, I wouldn't advise to do that. It's actually, I think, not used in the Netherlands, but you're also not allowed to use it in the Netherlands anymore. Then nowadays, plenty of light-cured capacitors are used and much popular to people in dental surgery. Is there any study yet about the vulnerable side effects of light-cured composite others? Two side effects that you can talk about. One, to the operator, to the dentist. You have to have the orange shield if you use light-cure composites, because the ultraviolet lights are very dangerous for your eyes. They can damage your eyes very easily. You live in a sunny country, so you should know when it's sunny, everyone's wearing sunglasses. The other thing with light-cured composites is if they're not are not cured well enough, they will leak bisphenol A, and bisphenol A is a hormone disruptor. So if you get too much of that in your body, then it could interfere with your hormones. And if your composite is not cured well enough, it could leak in your mouth and in your body for a long time, can give reproductive problems amongst others. But what most people don't know is that on the, I don't know if you have them also, those, do I have one here by accident? No. Those receipts that you got in the supermarket on the thin paper that are printed out, they have a lot of bisphenol A also. You have to look it up in on the internet. Really high, really dangerous. Some people refuse to even touch them. Very health aware, sensitive people. So how much you can get from the composite depends on how well it is cured. So it is very important to have like a really good composite gun or another kind of curing light. So the better the composite is cured, the less chance there is for resistant to leak bisphenol A. Then this is the last question. It's difficult to give an answer. So because that takes a lot of time. If you extract the tooth and you want to treat it, you want to have it outside the mouth as little time as possible. What we try to do is to have the tooth back in the circuit within 6-7 minutes. What we do is we first do the retreatment. We give it some time to heal, because sometimes you don't expect it, but it heals, and then you don't have to do anything. Otherwise, let's say it's all the way in the back, a lower molar, and the bone is too thick, and the patient can't open their mouth, and you cannot do apical surgery. Then we extract the tooth. We do the apical surgery outside of the mouth, put a retrofill in. I'll try to do all that within 6-7 minutes and put it back in the socket. So yes, you can do that. What is the average success rate? That I think depends on the operator, and also how fast he is, because the shorter is out of the mouth, the better. Also, what kind of materials he's using, and what we do with those teeth, we soak them in Henk's balance solution to preserve the periodontal ligament as much as possible. My success rate over the years is about 75%, but it also has to do, of course, with which cases you pick. If you can see in advance if there's a reasonable chance or that it's a lost case, that will make a difference. I have a colleague who has 100% success rate, but he has only done 5 so far. So it's too soon to see his failures. That's about it.
Okay, thank you, sir. It has been very nice discussion, and I know that in spite of having illness, you give us time, and it's our pleasure. Thank you, sir. There are some live questions from our dentist, and one question from the Sheikh Hannan. His question is, sir, should we go for implant this time?
So how do I go for implant? And then?
Yes. His question was, sir, should we go for implant this time, this pandemic situation?
That's difficult to say, because that depends on the case, also the favor of the dentist. I know in the US there are a lot of endodontists who also do implants, and they can make a better choice if it's still treatable or retreatable, or that it's better to do an implant. And as a service for the dentist, they often do the implant. I also have a colleague in my study club who is actually an endodontist or an implantologist, and he does like really very, very nice endo. So he's never tempted to do an implant because it gives him more money, or to do an implant because it's less work. It really depends on the dentist, the case, and the patient, of course. Does that answer the question?
Thank you, sir. I think, Dr. Hannan, you get the answer. Another question from Dr. Famasuddin Choyan, and his question is, what is the irrigation protocol in Netherlands in case of root canal treatment with a periapical lesion case?
There's no really right protocol. There's a lot of people who do it in one visit. And there's also a lot of people who put calcium hydroxide in and do in 2 visits. I do a lot of 1 visit, even if there's a periapical lesion. But let's say you do 2 visits from half an hour, so that's an hour total, or you do 1 visit, but you take 2 hours to treat the patient, to do it very meticulously, to clean it very well, then I think a 1 visit treatment is in that case better than 2 very short visits. So 1 or 2 visits doesn't mean everything. And as long as you clean well, you instrument very carefully, because if your files are too thick and you push too much debris through the apex, then there's a lot of chance that you will get irritation or inflammation of the apical lesion. If you do it slowly, start with small files and take care that you don't push your debris through the apex, then there's very little chance that the patient will have problems afterwards. Another thing that is important in this case, is because I also see a lot of emergencies, is that most of the emergencies that I see where the periapical lesion flares up is because the filling or the temporary filling is too high. I always check and take care that if the patient bites and grinds, that there are no or minimal contacts. Most of the patients with pain afterwards is because dentists didn't check the occlusion and articulation well enough.
Thank you, sir. Another question from Ashik Iqbal. He said, what kind of precaution we should take during root canal procedure in this pandemic situation?
Can you repeat that again, because I have bad sound? What kind of precautions?
What kind of precaution, yes, we should take during root canal procedure in this pandemic situation, in COVID-19 situation?
As I told you and showed you during the lecture, we don't take any other precautions than that. The only thing that we do that I haven't shown here is we let the patient rinse with hydrogen peroxide, put the tooth or rubber down, and before we start drilling, we also disinfect the teeth with either sodium hypochlorite or hydrogen peroxide. But other than that, we take no other precautions than I've shown already. Oh, and good suction, of course. That's very important. But because our assistants, they work under the microscope, they can place the suction, high volume suction, very exactly where it has like the maximum effect.
Thank you, sir. Actually, the ending of learning is, there is no ending of learning. And you related so many study club, as you mentioned. And I have fortunate that I visited your office, which is very well modernized and well equipped. And for the young dentist who want to be an endodontist, as we all know that you are the legendary professor in endodontist. It's all over the world, and you deliver your lectures, dozens of lectures in home and abroad. And what is your advice to the young dentist who become to be a good endodontist?
I think I answered that already, and you just gave a good summary of that. It's actually that you never stop and you're never done learning, because there's always new instruments, new procedures, new developed commands. So if you want to keep track, then you always have to go forward. There's no other way.
Thank you, sir. Thank you so much for your valuable and informative words of wisdom. It will be great pleasure and for us to listen to you again in future. And take care and stay safe, sir. You want to say something
It was
in the concluding speech, sir?
It was a pleasure seeing you again, Dr. Jan. I have good memories of the time when you
Thank you.
visited